Good morning. Good morning, everyone. Thank you for joining us. We'll get started in a second or so. We're going to let folks trickle in to the Zoom space. Welcome, welcome, welcome. I love them seeing video cameras on, so please feel free to turn your cameras on and engage in this interesting conversation that we're about to have discussion today. All right, so I'm going to go ahead and give a brief overview before we get started. My name is Damilola Jolayemi, and I'm with the Center for Behavioral and Addiction Medicine at UCLA. This is the case-based learning collaborative on Stimulants CME series. This series are held on the first and third Fridays at 12 p.m. to 1 p.m. And we've been having really great discussions since we started over the past few months. We started in October of 2023. The series are actually sponsored by the Center for Behavioral and Addiction Medicine at UCLA and the Department of Family Medicine, and also in partnership with Los Angeles County Substance Abuse Prevention and Control Program and the UT Southwestern Clinical Trials Network Big Southwest Node. I'm going to go ahead and skip the objectives because we've seen this so many times before and move on to our housekeeping items. So we ask that you use the Q&A for questions and the chat for comments during the session, but of course, feel free to intermingle if you can only find the chat. During the presentation, there will be questions that will be asked by the speaker, so we encourage you to participate, use the chat, or raise your Zoom hand and unmute. For the CMEs, again, please send all your CME questions to me my email is right here, and I think most of you have received emails directly from me. We do ask for your patience as we're going through this process of getting your credits ready, but if you do require a certificate of attendance, please let me know and we'll get that to you as soon as we can. Closed captioning is enabled for this meeting, so please feel free to use that. Past presentations are available on the CBAM website. This presentation is also recorded and will be available after the session for you to share or for you to go back and review. So that email will go out sometime next week. Our next session is on Friday, April 5th. So we have about 3 weeks from that. It's the first Friday in April, and the title is Pregnancy and Perinatal Care for Women Using Stimulants and Adolescents in Stimulant Use Disorders. This faculty presenter is Kelly Tsai, Assistant Professor at Boston Medical Center. So we're going to go ahead and start the presentation that we have today with Dr. Daryl Shorter. I'm going to call on Dr. Shapta, who is the director at CBAM and co-chair for this series, to introduce our speaker today. Dr. Shapta?
Thanks, Dami, and thanks to everybody who's here. I see in the chat, Enrique, can you check and make sure there are any audio problems and help solve that? I see a couple people who are having problems. I'm super excited today. Dami, can you take down the slide that you have here? I'm super excited. And the reason is because this is our first and only so far presentation that we've had on managing psychotic symptoms. And today we're very fortunate to have a national leader on the thoughts about managing psychosis from stimulant use disorder, Daryl Shorter. He's the medical director. Dr. Shorter is the medical director of addiction services at the Manager clinics and is also working in the outpatient assessments section there. He's associate professor in the Manager Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He is prior to being at Manager, he was attending psychiatrist at the Michael DeBakey Veterans Administration Medical Center in Houston. He's written many papers and placed them well. Many of his papers are in the guidebooks like the ASAM Principles of Addiction Medicine, as well as in contributing chapters to Biologics to Treat Substance Use Disorders, Vaccines, Monoclonal Antibodies, and Enzymes. He's a member of the AAAP, the APA, the American Association of Directors of Psychiatric Residency Training, and he is a participant in science. He participates with reviews for journals, and he is absolutely fantastic in helping to understand person-centered care for people who have problems with stimulant use disorder. As I said, Dr. Shorter I am super excited. I'm like ready to hear, and I know the rest of us are, and I'm going to get out of the way, but your expertise as a psychiatrist in managing psychiatric symptoms like psychosis in the setting of substance use disorder is fantastic, and I look forward to hearing more. I also want to point out today is match day, so happy match day if you're in the business, and we'll talk to you on the other side. Daryl?
Thank you so much, Dr. Shoptaw. I really appreciate the invitation and the opportunity to speak with your audience today. I probably should have asked my mom, my dad to be on here. That was quite an introduction. I'm always trying to make them proud, and they should have heard that one. So when we first started talking a little bit about what I might come to speak to you all about today, the idea and the topic of stimulant-induced psychosis came up. And so my hope is that today you'll walk away with a better understanding of how to tease apart the various psychotic presentations that could take place within the context of stimulant use, give you some ideas about how you might go about treating those things, diagnosing and treating them. And then maybe if we have some time left at the end, we'll talk a little bit about pharmacotherapy for both cocaine and methamphetamine use disorders once the person has been stabilized. I really do encourage people to utilize the chat and utilize the Q&A. I do want for this to be a little bit more of a conversation. I'd like to understand kind of your thinking and perspective on things, what you're seeing, and how we can kind of think together collectively about how best to address and to manage this. So with that, I'll go ahead and share my slides and get started. So today we will be talking about how to unravel the complexities in the diagnosis and management of stimulant-induced psychosis. And I recognize that maybe not everybody on the call here is a psychiatrist, but I want to first, if I can, reassure you that even psychiatrists and even addiction psychiatrists can sometimes struggle with really understanding what exactly is going on with patients who are presenting with psychosis in the context of sort of ongoing or recent stimulant use. And so these are my disclosures. We'll talk a little bit about prevalence, something about risk factors, definitely a lot about clinical manifestations. We'll try to compare and contrast stimulant-induced psychosis with other types of psychotic disorders, schizophrenia in particular. And then my hope is that you'll walk away with a really person-centered treatment approach for how to manage stimulant-induced psychosis in both acute and in chronic settings. So a lot to cover, and certainly want to leave time for questions and answers. So I want to begin with a case because I feel like that always kind of helps to ground the conversation. This is a representation of kind of sort of an amalgamation of folks that I've taken care of here at Menninger. We have both inpatient psychiatric hospital as well as an outpatient clinic, and so this first case will be an inpatient case. 25-year-old Caucasian male. He was admitted voluntarily to the hospital. He endorsed a 2-week history of manic symptoms. And by that, I mean, he was reporting a fluctuant mood, lots of mood swings. He had decreased need for sleep, racing thoughts, but that was occurring primarily within the context of stimulant use. He was also endorsing a longstanding history of severe depressive symptoms in the past. And at the time of presentation, he was reporting depressed mood, feelings of guilt and worthlessness, low energy, which he described as exhaustion, as well as passive SI. He also reported a belief that he and his families were the victims of an elaborate cyber attack via mobile device. He believed that the perpetrators were still trying to extort them. He was also hearing whispers of others making comments about how he and his family were in danger. It's really important to note that his mental status exam was otherwise unremarkable. So he could talk about these things in a linear and sort of goal-directed fashion. Although he did report this sort of delusional content, he was otherwise fine in terms of his thought process. He was depressed on exam, as he talked about in his original presentation. He was also quite motivated for treatment, which is something that I was very fortunate to encounter because of the consequences of his substance use. So one of the first things that I always try to do, both in my own clinical practice, but also when working with medical students or residents or fellows, I try to help them understand that establishing a chronology, establishing the timeline is perhaps one of the most important parts of our overall history taking. So I'm going to demonstrate that process for you today, how I try to get the residents and the fellows to do this. So this is a guy who began at the age of 14 with nicotine. That was his first substance. And by the age of 15, he was a much more regular smoker. And over the last 10 years or so, he found that his tolerance increased. Went from smoking about a quarter of a pack a day to half a pack a day. And by the time he presented to our unit, he was smoking roughly 1 pack per day. When it comes to alcohol, he was an early drinker. He started drinking around the age of 15. And initially, it was sort of sporadic in nature, primarily on weekends with friends, very social. By the time he hit age 16, however, he found that his drinking was quite a bit more regular and was actually becoming disruptive in school. He also began cannabis use around the age of 15. And again, sort of began with this kind of weekend use of cannabis, but over time gradually found smoking more and more regularly up until the point where he was about 17 or 18, where he became a daily user of cannabis. It was around age 16 that he first encountered opioids. He was given an opioid by a classmate and sort of liked it, enjoyed the effect that that he received from it. Found that over time, by the age of about 17, certainly by the age of 18, that he was obtaining and purchasing hydrocodone counterfeit pills wherever he could get them, and using anywhere from about 15 to 20 10-milligram hydrocodones per day. It was certainly around age 18 that he introduced benzodiazepines into his overall substance sort of repertoire, and he used primarily benzodiazepines. He used them in the context of opioid use primarily at first, and we'll talk a little bit about how his benzodiazepine use changed once psychostimulants were introduced. Now, his history of being prescribed Adderall and Vyvanse actually dated back to the age of 12, so it was before even his first use of nicotine. By the time he reached 16 and he was using opioids a little bit more regularly, he actually had stopped being prescribed medications for ADHD and really wasn't particularly interested in taking those medications anymore in an effort to really just sort of feel the effects of opioids and benzos. It was around age 18 that he first encountered cocaine, which he just sort of lit up like a Christmas tree, truly. Really enjoyed the experience of cocaine. And then 6 months later, almost a year later, was exposed to methamphetamine for the first time and had a year of about a year of regular methamphetamine use before this kind of combination of multiple drugs ultimately resulted in him having a legal consequence and then seeking treatment. After that, he was able to remain abstinent for a full 3 years. During that time, he participated in mutual help groups, reports like sort of doing well. He got married, got a job and as a trade, and was doing quite well. At age 23, about 2 years prior to his presentation at Menninger, he began drinking and smoking cannabis again. Things were going so well, I think he just sort of thought like, I'll try it, and I'm sure that things will go okay this time. Shortly after introducing alcohol and cannabis, cocaine came back into the picture for him. And then opioids came back into the pictures for him. Now, what was interesting about his opioid use more recently was that in comparison to several years ago, fentanyl was also involved in recent opioid use. He also found that his hydrocodone use had increased from prior times where instead of using about 15 to 20, so taking up to 200 milligrams per day of hydrocodone, he'd actually been able to push that tolerance a little bit further and was taking up to 300 milligrams of hydrocodone per day, in addition to the cocaine. Now, what you may see is that the cocaine use stopped about 6 months before he came to the hospital to see us. And that's because the methamphetamine crept back in for him and he began using methamphetamine more regularly. And it, in fact, identified that as the primary issue, which was contributing to what his admission at that time. I want to also point out that during that period of sobriety, during that period of abstinence, this was someone who was otherwise doing quite well. He really denied depression, anxiety, wasn't really in treatment, wasn't receiving medications, and certainly was not psychotic. So a lot of thoughts might come to mind when we're thinking through the history of someone, especially in this case. So I want to ask, and hopefully the polling will work for us, which of the following actions would be the most appropriate next step? And I want to acknowledge that kind of all of these are things that we might want to do or should do as part of our overall treatment of a patient who presents in this fashion. But I'm just sort of interested to see how you might think about or respond in a case like this. And you'll have to tell me how I can look at the results. Maybe there's a...
Dami, can
Would
you?
you like us to end it so you can see the results?
Oh, sure. Yeah. Okay. I could do that. Should I stop sharing?
Oh, no, you're fine.
Oh, okay.
I think you're ready to see it. Give me a second. All right, we have 52 out of 890 participated. I'm gonna go
Okay,
ahead
we'll
and
keep
end
going.
it. Oh, sorry.
Great. All right. So the majority of folks would go right to performing a medical evaluation, getting labs, doing sexually transmitted infection screening, perhaps ordering additional medical tests like head CT, LP, EEG. Great. Some folks would go right to managing the acute poly drug withdrawal, which I think is probably a good consideration, given that this is someone who had been recently using opioids, and opioid withdrawal could maybe represent a risk for him in terms of early discharge. Some folks are going to go right to trying to treat the unspecified psychosis. We're calling it unspecified psychosis at this point from a psychiatric diagnostic standpoint because we're not really sure if it's stimulant-induced or if there's now a primary psychotic disorder. Certainly, the report of suicidal ideation is of great importance to us, and certainly we would want to consider what to do about that. And then also, of course, it's really important to provide motivational interviewing and try to promote establishment of abstinence as well. So I want to say that I think where we might end up going with this particular case is we would try to stabilize the opioid withdrawal first. Because if this patient gets really, really, really uncomfortable, and this is something that you might be able to begin either in an office setting, you can do it in the ER while the patient is waiting for admission. Let's try to get this person as stable as we possibly can from an opioid standpoint, very easily with a Suboxone induction. And then we can try to address some of these other issues, like the psychosis, and certainly performing the medical evaluations. So this is great. Oh, did I not share? Okay, good. Okay. So other considerations that might come up when you hear a history like this, one of the first things that I think clinicians can sometimes struggle with or have questions about is the presence of ADHD. Like, what do I do about that? Like, should I treat it? Should I not treat it? How much did this ADHD and the fact that this particular individual was treated with medications like Vyvanse, like Adderall as a teen, how much does that sort of contribute to the presentation that we see today? Understand that untreated ADHD represents more of a risk for developing a substance use disorder. And I think it's really important to note in this case that the symptoms of psychosis did not occur during the ADHD treatment. They developed not even during the first period of time where this patient was using psychostimulants, but rather during the more recent second time that he was using psychostimulants, and he had that period of time where he was using methamphetamine. And his methamphetamine use was daily, heavy, all day for almost about 5 weeks straight. It's also important to consider the specific substances that might be contributing to what it is that we're seeing. And cannabis is kind of at the top of the list. This is someone who began cannabis use during his adolescence. And of course, one of the things that we would talk to the patient about as we're performing motivational interviewing and better understanding the patient's goals is how cannabis use might contribute to or worsen things like anxiety, like depression, and even perhaps psychosis. Alcohol, opioids, and benzodiazepines to a lesser extent might be contributing factors when it comes specifically to psychosis. Not to say that there's no chance of it, but certainly would be perhaps a little bit lower on our list. And one of the reasons we're a little less concerned about alcohol in this case is because he'd been not abstinent from alcohol for about 6 months prior to his presentation. Now, if this were someone who came in and he was actively using alcohol and opioids, absolutely that would be a situation where we would want to really stabilize the withdrawal as well. And of course, psychostimulants while we're here today. Importantly, the period of abstinence tells us that the likelihood that this is stimulant-induced is perhaps a bit higher. Not necessarily guaranteed, but certainly a bit higher. And then we begin to tease it out from there. When it comes to things like the differential for diagnosis for psychosis, for agitation, and these are recommendations taken directly from the recently released ASAM-AAAP guidelines for treatment of stimulant use disorder. These are the indications to perform some of that medical workup that was mentioned. Certainly, if the patient comes in and they have altered mental status, or they have neurological symptoms, or if they've had history of trauma, or if they're found in a way where you're not able to even collect history, that would be a time that you would consider getting the head CT. In this case, however, this was someone who presented walking and talking, mental status exam was otherwise unremarkable, and so our urgency around getting a head CT might bump down just a little bit, not to suggest that we wouldn't necessarily get one. Same thing is true for the LP, a lumbar puncture, or an organ blood test specifically for encephalitis. This is a patient who did not have fever or meningeal signs or symptoms. However, if those were present, you would absolutely bump those types of assessments up to the top of your list. When it comes to EEG and whether or not you should order an EEG, certainly if someone is having seizure activity, especially if you can't explain it, that would be a case to order EEG, as well as other sorts of neurological symptoms or signs that you just can't explain. Definitely if the individual has encephalopathy, that's a time that you would want to order EEG as well. Other things to consider would be things like hormonal, endocrine, and infectious causes, as well as oncologic causes, or one of the sort of bugaboos of psychiatry, NMDA receptor encephalitis. So just a quick word about sort of prevalence of stimulant-induced psychosis. This has been something that people have spent a lot of time thinking about and trying to better understand. But before we get to the stimulant-induced psychosis, let's just talk stimulant use in our country. So SAMHSA's National Survey on Drug Use and Health, most recent data looks at 2022. And what we see is that by far in our country, the most commonly used psychostimulant, CNS stimulant, is cocaine, with an estimated 5 million, above 5 million folks who use cocaine. Next would be prescription stimulants, where about an estimated 4.3 million. And then after that, you've got almost 3 million folks who are methamphetamine users in the past year. Now, what I think is really particularly interesting about that data isn't just how many people use it. It's really who is using these psychostimulants in combination. And it looks like almost 20% of stimulant users are people who use some form of psychostimulant with another type of psychostimulant. So in the case that I described, this was someone who had a history of using both cocaine and methamphetamine. This really, I think, means from like a diagnostic standpoint, certainly in our collection of history, it becomes really, really important that we focus not just on the person's use of what is going on most recently. So when someone comes to us, hey, do you use psychostimulants? Yeah, doc, I do. What's your what do you use? I use methamphetamine. The automatic next two questions should be, okay, what about your use of cocaine? And what about your use of prescription stimulants? We want to be complete and as thorough as possible in understanding which particular stimulants are contributing to the presentation that we're seeing in that moment. So when it comes to the ages of people that are perhaps most likely to present, it turns out with our prescription and stimulant users, more likely to see someone who's between the age of 18 to 25. That is also true for cocaine, with folks that are 18 to 25 perhaps being more likely to present in some of our treatment settings. But then when it comes to methamphetamine, perhaps we're more likely to see folks age 26 or older. So again, something to kind of think about as we're doing screening and providing education to patients, families, and communities about the age groups that might be most vulnerable to using certain types of substances, particularly stimulants. So here we go with our second question. So the doc initiates buprenorphine for opioid withdrawal, rules out the medical concerns. Which of the following medications do you think would be most appropriate? And here we go with another poll. If we can get to 50 people, we're at 43. But I like where we're going with this. Most. Okay, I'll go ahead and end the poll. Oh, wait. Now we got 50% participation. Awesome. Oh, a little bit more. Okay, we're at a minute. Great. So olanzapine came out at 44%, and there we go. You all can see that. So our treatment considerations when it comes to which antipsychotic to use in a situation where someone presents with stimulant-induced psychosis. Olanzapine and quetiapine have been found in a meta-analysis to be superior to risperidone. Now, there are certainly colleagues who might feel a bit more comfortable prescribing risperidone. That might be sort of their initial sort of knee-jerk reaction when it comes to prescribing medications. But I think in situations like this, we might want to pivot and try to really strongly encourage folks to use something like olanzapine or quetiapine. It's interesting, olanzapine and haloperidol or Haldol have been found to really have kind of equivalent efficacy, but perhaps fewer side effects and faster symptom resolution with olanzapine. There's also, I think, greater familiarity more recently with the use of these atypical second-generation antipsychotics for treatments of things like psychosis and agitation. So you might, again, still pivot toward olanzapine as opposed to Haldol. So when it comes to aripiprazole, interestingly enough, it's been found to be inferior to some of these other medications, and so might not be our automatic go-to in a situation where someone has psychosis. Important to acknowledge that both clozaril and chlorpromazine can increase seizure risk, and so would not be indicated in a situation where you're treating stimulant-induced psychosis. And then there's the big question that's almost always hanging over our heads. How long do I use this medication? Do I use it up until the time where perhaps symptoms resolve and then think about peeling off medications? Still sharing for some reason. Or do I continue this medication indefinitely? And one of the things that I want to kind of help people to think about is just this question. We've got someone in one of our programs right now where we're wrestling with whether or not the stimulant-induced psychosis that this individual presented with, whether or not it's a good idea to pause or reduce the antipsychotic medication that was prescribed. Well, the presence of ongoing symptoms of psychosis absolutely dictates whether or not we should do that. So even in a situation where you might have the resolution of some symptoms of psychosis, like perhaps paranoia or delusional thinking, if the voices remain, you continue to treat until you reach and achieve symptom resolution. So when it comes to really teasing apart this diagnosis, I think that that's probably the hardest part of this whole thing, because you can try to establish the chronology, you can do your careful timeline and still be left with a big question mark. So I'll begin by talking just review of schizophrenia, the diagnosis directly from the DSM-5. So for the diagnosis of schizophrenia, what you need are 2 or more of the following delusions, fixed false beliefs, hallucinations or perceptual distortions. Those perceptual distortions could be either auditory or visual. They could also be tactile, gustatory. So lots of different sense experiences that might be distorted. There's the possibility of disorganized speech, where people might become derailed or incoherent, sort of grossly disorganized or catatonic behavior, and also the presence of negative symptoms. So two or more of those. If the person experiences impairment, if they have those two symptoms and impairment for 6 months or more, and you've ruled out medical causes, substances, or the presence of something like a mood-related disorder like schizoaffective disorder or bipolar disorder or depression with psychotic features, that individual would meet criteria for schizophrenia. In comparison, we have substance-induced psychosis, which really only requires the presence of one or both delusions or hallucinations. In addition, you have the historical evidence that symptoms developed either during, and get this, or within a month of intoxication or withdrawal. So what that means or could mean is that somebody might present, not necessarily during the period of intoxication, maybe they present to you in a period of withdrawal or even after withdrawal, but they're still reporting symptoms of psychosis, either delusions or hallucinations. And if it seems that there may be a relationship from an etiological standpoint from that use to the psychosis, it's possible that substance-induced psychosis is what you're looking at. Of course, you'd have to rule out delirium, and of course, the person is going to be experiencing some distress as a result of those symptoms. When it comes to the pathogenesis of substance-induced psychosis, there's lots of different ways than neurotransmitter systems that might be in play or contribute to why it is that this exists. And I've tried to group them here by the most prominent or most involved neurotransmitter. In the case of psychostimulants, like the ones we're discussing today, we've got dopamine that's primarily involved, which is why atypical antipsychotics and medications that impact that system are frequently used, as well as cathinones. We've got CB1 receptor agonism that could be a part of it. Certainly our serotonergic hallucinogens and things like 2C. 2C is another 5-HT agonist. We've got NMDA antagonism, really that's sort of prototypic thinking about like psychosis, PCP, perhaps ketamine, and then also our kappa opioid receptor activation, which you can see with things like salvia and kratom, which I'm seeing increasingly from a clinical standpoint, more and more people presenting with kratom use because of its widespread availability in head shops and sold alongside THC and CBD. So when we think through the sort of the progress or the progression of stimulant-induced psychosis, it's really important for us to ask ourselves certain questions. One, at baseline, is psychosis present? Because if psychosis is present at baseline, we're not even necessarily talking about stimulant-induced psychosis. We're really talking about the exacerbation of a primary psychotic illness. And make no mistake, there are certainly people who have a psychotic disorder who also engage in substance use and might use the psychostimulant, despite the fact that it actually can worsen their symptoms of psychosis. So we begin with that question: is there a primary psychotic illness at baseline? Then, of course, sometimes we might encounter people, particularly in our emergency room settings, but not always. People sometimes will present to our outpatient settings and we can certainly present to our offices having recently used or engaged in substance use. And so they might present with transient psychotic symptoms in the context of acute intoxication, sort of regardless of where we might be encountering those folks. Then, of course, I think maybe one of the more difficult ones for us to really tease out is what happens if someone has been using a psychostimulant chronically for a very, very long time. We're talking about 15, 20, 30 years of cocaine use, on and on and on. And those folks can actually develop a syndrome that really resembles a primary psychosis, particularly if there are not longer periods of abstinence or time away from the stimulant use. So here we go with our big comparison of the different types of psychosis that people can experience. So we've spent some time just now defining what schizophrenia looks like. We've got positive symptoms, negative symptoms, and it becomes really important, I think, and helpful to consider this a thought disorder, to really focus on how people might also experience disorganization in their speech, disorganization in their behavior, and they have those prominent negative symptoms, avolition, et cetera. That's in comparison to cocaine or cocaine-induced psychotic symptoms or cocaine-induced psychotic disorder, which are a couple of different ways of us understanding what is going on with our patients when they use cocaine and experience psychosis. They're more likely to experience some sort of hallucinatory experiences, auditory more than visual. There's also the likelihood of experiencing paranoid delusions as well. It's not uncommon for people to experience behavioral abnormalities such as violence or aggression, and really important for us to also consider sort of the repetition, the repetitive behaviors that people can get into. Those could be anything from simple repetitive behaviors like skin picking, all the way to chronic repetitive behaviors like drawing or something along those lines. It's also possible that people might experience tactile hallucinations or develop things like parasitosis, where they feel like there are parasites literally crawling under their skin, might contribute to skin picking or scratching. That's quite a bit different from what you might see with methamphetamine, where persecutory delusions are certainly a big part of that versus kind of paranoia. You again will have a hallucinatory experience that's perhaps a bit more auditory than visual, but certainly as present, perhaps more likely to experience hostility. But then there's a kind of a conceptual disorganization. People seem really quite, it almost could look like a schizophrenia in terms of the amount of disorganization that people can experience, really, really struggling with thinking things through. And of course, depression can be a very prominent part of that presentation as well. When it comes to prevalence, it's interesting, it's probably approaching about 1% prevalence of schizophrenia worldwide. It seems to be more male than female, although you might look at some studies or some reviews or meta-analyses and find that it's actually equal. Migration status seems to be a risk factor for the development of schizophrenia, as well as urbanicity and higher latitude. So that might have something to do with biometeorologic factors such as like temperature, UV radiation, precipitation. And so I think it's really important for us to just kind of consider the genetic plus environmental interaction that contributes to the development of schizophrenia for so many people. Here you've got prevalence data for current users and lifetime users, and I'm going to go ahead and skip forward because I want to make sure we get to our second case. It's impossible to have this conversation without really considering the potential role for cannabis. I don't know about you all in your clinical practice, but it certainly feels to me like more and more and more every day I'm having conversations with folks about cannabis. And so while I'd love for people to come in and be purists and just use cocaine or just use methamphetamine, there's almost always like this foundational use of cannabis that is underneath it all. And especially if that cannabis use began during adolescence, it does raise some questions about whether or not there is increased risk for developing psychosis in that context. And as it turns out that both lifetime and recent use of cannabis is associated with cocaine-induced psychosis. However, there are some phenomenological differences, especially with cannabis-induced psychosis, which seems to really be associated with a huge anxiety component and a lot of paranoia. So while they may interact with one another, it is important to kind of think about them separately and in terms of our conceptualization of them as psychotic illnesses. Some risk factors for development of cocaine-induced psychosis include things like, which makes sense, if somebody began using at a younger age, if they had been using for a longer period of time, or if they've had greater severity of their cocaine use, obviously all of those things could serve as risk factors for cocaine-induced psychosis. If they have had an episode of previous psychosis, of course, that kindling effect could mean that the individual is perhaps again more likely to have another type of episode like that. ADHD, again, the complication of ADHD, treated versus untreated becomes a question when it comes to cocaine-induced psychosis. Certain personality styles or personality traits or disorders are associated with as a risk factor for cocaine-induced psychosis. That includes antisocial personality disorder as well as borderline personality disorder. Male gender, lower BMI, and I wish that like clinically we could use this a little bit more easily, but sometimes even genetics can be help us to better understand the risks that someone might have for cocaine-induced psychosis. When it comes to methamphetamine-induced psychosis, more frequent use, in terms of, again, the kind of same thing. If you use more frequently and you have greater severity, you're more likely to develop psychosis. In this case, however, because methamphetamine can oftentimes be used with other types of substances, especially in party situations where people might be combining with things like MDMA or GHB or ketamine or alcohol or cannabis, that polydrug use and certainly the way that people kind of use for days and days and days on end and don't sleep for days and days on end, that combination in terms of the ways that people use might also serve as a risk factor for going on to develop meth-induced psychosis. The nature of the meth that people use might actually have something to do with it. If they're using shake versus other types, comorbid depression or anxiety, which I think gets into some really interesting questions about whether or not someone has depression with psychosis, plus meth use disorder and teasing that part of it out versus are they experiencing depression as a result of meth withdrawal? And they also have psychosis. So again, very, very, very complicated from a diagnostic standpoint. And then finally, family history. So our second case.
Before we get there, Daryl, there's a question in the chat.
Yeah.
Dr. Coffin asks, what do you think about providing a small amount of olanzapine as needed for patients who have drug-induced psychosis after resolution for self-administered use in case of another event? Just sort of like to have it to break glass when needed, sort of thing.
Absolutely. I love it as an idea. I think that one thing to kind of tease out with folks is the why of using a medication. And so I would really want to understand what are the particular symptoms or experiences that would make you feel like you need olanzapine. So if we're talking about anxiety, which people are going to get, if we're talking about a sense of agitation or irritability, yeah, olanzapine is a medication that can work for those types of symptoms as well. But that might not necessarily be psychosis. That could be sort of the intensity of craving that somebody might be experiencing as a result of abstinence or really trying to get out, like be and remain abstinent. Or it might signal that there's something else going on that I would want to tease out from like a depression standpoint. Maybe we have uncovered a bipolar disorder or something like that. So as long as we kind of understand the why of prescribing it, I don't really see a problem with it. But just like the patient should really be able to say like, listen, I'm really just agitated. My agitation is the reason that I'm taking this olanzapine. And okay. We're using it as a PRN in that the same way that we might use that medication on an inpatient service when people are experiencing agitation as a result of complex PTSD or symptoms of antisocial personality disorder or borderline personality disorder, emotional dysregulation, those sorts of things.
Great. Another question, are there differences for meth-induced psychosis risk based upon route of administration?
Yes, I looked for that, and it turns out nobody knows. I looked specifically for this question about whether or not, and I can tell you sort of anecdotally, one might suspect that intravenous use is probably higher than smoking, which is probably higher than oral, et cetera, et cetera. But it turns out when people have tried to do that head to head, it's not really clear from the data. And what's interesting is, I was kind of reflecting on this. Maybe perhaps some of the folks on the call today saw there was recent in the news that like it looks like people that are dying of poisoning or overdose deaths are actually now dying more from smoking the substance as opposed to intravenous for like the first time. And so that's really, so the way that people have been using substances, I think, is changing and shifting, and that sort of the dangers that are associated with has also changed and shifted. But that's an excellent question.
I have another excellent question here from Dr. Hirawa. Could you say more about the potential role of BMI in cocaine-induced psychosis?
Yeah, so it makes me think about sort of not just the route of administration, but the way that the volume of distribution of cocaine within the tissues, within the vasculature, how quickly cocaine might be delivered to the brain as a result of those sorts of things. And so just kind of something curious for us to be aware of, that perhaps our folks with lower BMI might be at risk for developing cocaine-induced psychosis. Yeah, good question.
Great. I think we're clear and good to go.
Okay, sounds good. And I'm going to try to motor. through our next case. All right, so we got a 43. This is a guy, sort of amalgamation of a guy that I saw in our outpatient clinic, came for care after already establishing abstinence in a 30-day residential program. Now, this is someone who reported a long-standing history of depression. He was currently reporting at the time of presentation mood swings. So not really saying I'm depressed, but saying I'm having a lot of irritability, I'm having highs, and I'm having lows. Poor sleep, low energy, difficulty with concentration, and feelings of guilt related to like relationship and job loss. He was also reporting constant voices, which he felt really worsened with cocaine use prior, but had not gone entirely away. He described that when using, the voices became more critical, but he was pretty clear that he was not paranoid. Like, I know I'm safe, but like these voices are just wearing me out. And at the time of presentation, the last use of cocaine was about 1 month prior. So we use our timeline. We'll go from 15 to age 43. So not a smoker. This was someone who began using at around the age of 16 and very quickly developed pretty severe AUD, getting first DUI at the age of 18, second DUI at age of 19. Cannabis use came along the way around age 18. After that period of sobriety, like the second DUI hits, life sort of happens, he's able to like stop drinking, get sober, pull himself together, manages to go to college in the 4-year period, graduate, gets a job, life is going well, age 25, all right, things are going pretty good. I probably can drink now. So he begins drinking, things go well, is able to retain a job, so not really experiencing and not like immediate symptoms of AUD or immediate consequences or negative consequences from drinking. Adds cannabis back in large part because things were not falling apart as a result of resuming alcohol use. It was around age 30, however, that cocaine entered the picture. It really took the cocaine, really enjoyed it, liked to party. And then toward the very end of the second stint of substance use, right before age 35, had about a year of pretty solid meth use in addition to cocaine use, cannabis and alcohol. All of that kind of brought things to a head. There was a job loss and another situation that happened resulted in going back to treatment and going back to 12-step mutual help groups. Period of sobriety this time did not last quite as long before resuming alcohol use and cocaine use. Methamphetamine then came in sort of sporadically, and what took the patient into treatment the last time was the combination of alcohol and cocaine. Cannabis had sort of become not really as interesting or important. So important to also note medications at the time of presentation. This was someone who was taking HIV PrEP, was on bupropion, extended release, 300 milligrams a day, so a good dose. Armodafinil, trazodone for sleep, and was also receiving testosterone injections. So final question for our poll today. Which of the following actions would be the most appropriate next step? You could continue the current medications. So we've got PrEP, we've got Wellbutrin, we've got armodafinil, we've got that trazodone, we've got the testosterone. You could discontinue the bupropion and the armodafinil. You could consider initiating treatment with something like oral lorazepam or Ativan, initiate treatment with oral risperidone, or initiate treatment with oral extended release valproic acid or Depakote. So what we're thinking about here are presentation. Last use of cocaine was 1 month prior to seeing you. 30 days of abstinence in the context of a residential program, started on antidepressants, including bupropion, also started on this medication, armodafinil, which can be used off-label for ADHD, but certainly can be used as part of sleep apnea, and reporting mood swings, irritability, highs and lows. Much more challenging, admittedly. So if you're struggling, please know that you were not the only person on the call today who might have experienced some struggle as well with trying to think through like what is the most appropriate course of action. Okay. Just another few seconds. Great. And let me pull and share the results. Okay. So we have the majority of folks continuing the current medications unchanged while completing the medical evaluation, and then kind of equal parts discontinuing the medicine, initiating an Ativan or Depakote or risperidone. Yeah, very, very difficult, very challenging case. So let's talk through a little bit about like what each of these things can or should do for us, right? So continuing current medications while completing our med evaluation. This is someone that is coming from a residential treatment program. Hopefully you've got an opportunity to get some records from that individual. That would be like a great place to start. Having a better understanding about like from a medical standpoint, what's going on with them. However, this is a person who presented and was medically stable otherwise. The interesting question about the bupropion and the armodafinil is really one about whether or not it is contributing to mood instability and or symptoms of psychosis. And so trying to get a sense from the patient about when armodafinil was started, when bupropion was started, and how those particular medications have interacted with mental health symptoms would be a really important second line of questioning to try to consider in something like this. Discontinuing both of those medications at the same time could also result in significant mood disruption. So you might find that the patient's mood bottoms out, that their depression really gets quite bad, or their irritability shoots through the roof. And so just discontinuing those medications together might not necessarily be how you would approach. You might try to do one versus the other if that was something that you were thinking about doing. The lorazepam is a little bit of a sort of a red herring. It might be helpful for things like mood instability, but really we'd be thinking about that along the lines of perhaps treating anxiety. And because this is someone who's not necessarily agitated or presenting with agitation, the addition of Ativan at this point might complicate things from a pharmacologic standpoint. Certainly the addition of an antipsychotic for someone who's experiencing both symptoms of mood instability as well as symptoms of psychosis related to kind of the persistent chronic voices that he described would probably be one of the things that we would bump toward the top of our list in an effort to try to help give this guy some relief, to reduce some of the irritability and mood swings that he might experience as a result of recent cocaine use. And Depakote is an interesting idea, and while it might help with the mood instability, wouldn't necessarily address the symptoms of psychosis. Okay, so in our comparison of cocaine-induced psychosis versus schizophrenia, there are some points that might help us to tease out what's what. Like in this case, he presents, he hasn't used for 30 days, has had a period of sobriety, he's coming to you on medication, has had a mental health history, and you're still like, I don't know, is this substance induced or is this something more primary? So asking questions about family history. Was there a family history of substance use or a family history of psychosis? That might be one place to start. When exactly did you have the onset of your symptoms? Were there periods, even during the time where you were abstinent, where you experienced hearing the voices? Cocaine use, of course, is required in order to have a diagnosis of CIPD. This is someone who was reporting auditory hallucinations as opposed to visual hallucinations. No delusional context, no delusional content was noted.
Dr. Shorter,
Yeah.
a question from Lawrence Bryant. How is the medication adherence for those clients still using stimulants or other substances? Yes,
Yeah.
you're thinking about the medication. What about the question about medication adherence?
Yeah, absolutely. So I think it depends is my hedge on this. What I'll offer is that I invite patients to come back and tell me how the medication did not work for them. So when I'm talking to a patient about a particular medicine, I will usually say to them, listen, I've got no investment in this medicine other than it working for you. And so if you want to come back a day from now, 2 days from now, a week from now, and tell me, Doc, this medicine sucked, I'm like, great, thanks. Glad to know that. Glad you came back. And it's because treatment retention is partly about the medicine, but I think it's more about the relationship. Okay, I'm going to keep going because I think we're almost out of time. And I want to say a quick word about agitation, and then we'll stop. So when it comes to the management of agitation, things to know about meth-induced and cocaine-induced agitation in the context of psychosis is that as much as we possibly can, using our skills to calm patients, provide verbal or nonverbal de-escalation in those emergency room settings, in those early days of somebody being on a residential program or in a psych hospital or in one of our units, that is how we can really try to bring calm to our patients and to our teams. Benzodiazepines are, in this case, considered the first line of treatment for agitation. And then, of course, if psychosis is present, you treat with an antipsychotic medication like some of the ones I mentioned. Oral medications would be Haldol, Zyprexa, or olanzapine, risperidone, or you can give intramuscular injections for someone who's really acutely agitated with Zyprexa or haloperidol. So with that, I'm actually going to stop sharing. We've got like 2 minutes left for any other thoughts or questions.
That was great.
I appreciate all of your.
It was very comprehensive for all of us that we do like some inpatient medicine, addiction inpatient consults as well. I have one question. What is the prognosis for patients with psychostimulant-induced psychosis compared to those with a primary psychotic disorder?
So I would say mixed, but let me give a context. If I have someone who has developed a stimulant-induced psychosis and it's really clear and they have responded to medication, we've been able to keep them engaged in care, then I'm almost like, if we can really get you to buy into the idea of abstinence and sobriety, I have a really good, I'm feeling really good and really positive about your chances of not having another psychotic episode. If, however, someone has a primary psychotic disorder, that's where it gets a little bit more challenging. And I would never say that it's a completely hopeless situation. Of course not. But it may be more chronic in nature, and it might require perhaps a little bit more support. And there's lots of different ways that we can provide support to folks in terms of peer specialists and psychotherapy and groups and psychosocial rehabilitation. So yeah, excellent question.
One quick question. If you have concluded that this is stimulant-induced psychosis and it's not been chronic, and you start them on an antipsychotic, how long do you keep the antipsychotic on?
Such a good question. And it's the toughest one of them all. I knew it would come from you, Dr. Trivedi. It's great to see you. So I usually try to go for about 30 days. But I will say, I will sometimes stretch it to 2 months if they are in our intensive outpatient program. Now, that's just because of sort of the setting in which I work. And this is, I think, one of the challenging things about medical practice. Sometimes the decisions we make are dictated by the settings in which we practice. I also don't always want for people to be discharged from our programs on an antipsychotic if they really don't need them. And so if somebody is in a day treatment program or in an intensive outpatient program and we've got good eyes on them, that to me is the time to try to reduce the medication, because you're seeing them every day or you're seeing them 3 times a week or 4 times a week. To do this with someone when they're being seen once a week or every other week, or even worse, sometimes once a month, I think doesn't necessarily serve the patient the best. Like if we try a gradual reduction while you're in this program, but I know I'm going to see you later in the week, that to me is ideal. But if the plan is for somebody to be taper off of a medication and I'm only seeing them every 30 days, I get a lot more concerned about that.
Thank you.
Thanks. Yeah.
Dr. Shorter, this is fantastic. Absolutely amazing. I learned so much. And I have a new thought about how we can be thinking about working with our folks here in addiction medicine to address this issue. It doesn't necessarily, from what I'm hearing, just because we're in primary care doesn't mean we can't step into this space.
Oh no, we need you to. We need you to so desperately, because there's just not enough of us to go around. And so absolutely any work that you can do with our patients that are struggling with stimulant use disorders, absolutely appreciated.
Fantastic. Thanks so much.
Thanks, everybody.
Well,
Now-
thank you, and I want to highlight the chat. There are a lot of kudos to you, Dr. Shorter. Thank you for the presentation. We'll see you all on April 5th, which is in 3 weeks, for our next presentation. Have a great weekend.
Thanks, guys.